Richard Freund here, representing DHHS and the Office of Behavioral Health. We'll wait a few minutes as we gather and take our virtual seats. Welcome to the webinar. We'll just give it a couple minutes. It's not even 11:30 yet. We're still gathering, letting people come in. Hope everybody's enjoyed the first week of September. I think just about we had the best weather in the country. Not 110 like in Southern California. Again, thank you for joining us as we gather in the cloud. We'll be starting in just a couple of minutes. We let the most people in. As we did at the summit, we had to usher people to the front. All the good seats are up front. Please make your way in. So virtually, we all have a front row seat. Just wait another minute. All right. As I said, I'll introduce myself, Richard Freund. I'm with the Office of Behavioral Health. I am a substance use disorder program manager overseeing special projects. I'm happy to be here today to introduce the panel. And thank you to everyone for joining us. This is the first webinar in our new opioid response webinar series, which will begin today, September 6th, and continue the first Friday of every month until the governor's 7th annual opioid response next July. These webinars will be offered from 11:30 a.m. to 12:30 p.m. and will be available at no cost. They will also be recorded and available for viewing anytime following the event. This week, our opening webinar will feature the topic of Maine's recovery residences. There are presently over 80 recovery residences across the state, which are certified by the Maine Association of Recovery Residences, known as MARR, M-A-R-R. Updating attendees on the certification standards, the HSSP, the Housing Subsidy Services Program, and the metrics being collected on Recovery Capital will be Ron Springel, MD, Executive Director of MARR, and Peter Rosasco, Special Programs Manager for MARR. The program will be moderated by myself, SUD Program Manager, and the Office of Behavioral Health. And with that, I'll turn it over to Ron for introduction of his panel.
Thank you very much. Thank you very much, Richard. And thanks, Peter, for starting the slide deck. My name is Ron Springel, the Executive Director for MARR, Maine Association of Recovery Residences, and there's virtually 99 participants already. I was able to quickly look at the names of those of you who have put your names in, and the amazing thing is I recognize so few of you. There's so many names I don't recognize. And that tells me that a lot of you want to know about MARR and are curious and may not have had that much exposure or experience with us. Co-presenting with me will be Peter Rosasco. Peter is a data whiz and is the program manager for special programs, including the Housing Subsidy Program. Also joining us will be Scott Party, who is a member of the MARR board, serves as MARR president, and also the largest operator of recovery houses in the state, Fresh Start Sober Living in Penobscot County. Also joining us is Nicole LeMay. She is with Recovery Housing of Maine and Recovery Connections of Maine. They're together, two organizations that work together and provide both treatment and recovery housing. So we'll be speaking about her experiences with MARR and Recovery Capital and the housing subsidy programs. We will be leaving time for questions. And so there is a Q&A. There's also a chat, but we'll be looking at the Q&A specifically. So if any questions come along, feel free to put them in the Q&A section, and we'll do our very best to get to them. If we don't get to all of them, we'd be happy to follow up in the recorded session that will be posted online with answers to those questions. So our program today, next slide. Very briefly, I wanted to start out by talking about something that has not that much to do with MARR, but has a lot to do with recovery services in the state, and it has to do with medically managed withdrawal. I may slip and say detox. We like to say medically managed withdrawal, but it's much harder to say, so we say detox. I'm guilty of it. It has to do with the available beds. We want to fill them up, and so we want to be sure people have that information. Again, with a number of folks that may not be familiar with MARR or recovery residences, we will talk about what it is, about the classifications from the national group, NARR, the National Alliance for Recovery Residences. They're kind of our parent organization, and then some very basic, brief introduction to the timeline of addiction and recovery, and then some information about MARR by the numbers, but then getting into the meat of the program about recovery housing support programs. We have a couple of those to talk about, outcomes data, how we know these programs are working, and then with Scott and Nicole, what operators and managers think about the program. Fill them up. This is courtesy of MARR, Maine Recovery Advocacy Project. Courtney Allen and Tess Parks have put this together as a service. They've made this available. It was given out at the Governor's Summit, and it lists the amazing progress that we've made in opening up these beds for medically managed withdrawal. There's now over 100 beds in our state that accept Maine Care or other insurances. If we just think back a few short years to the pandemic, we were in single digits with available beds, single digits, 8, 9, 10 beds if we were lucky, for various reasons. And now we're in triple digits. Interestingly, we're not filling the beds up. There's a lot of reasons for that, we think, but a lot of it has to do with none of these places ever advertised before. They just don't have a budget for that. They never needed to because there were always waiting lists. Now most of them don't have waiting lists. What Courtney and Tess have done, and next slide, is they have posted on their Facebook page a daily availability of beds. Now I know this text is a little small, but you'll see in the middle, it actually lists those 6 organizations that are doing this service and if they have beds available or any notes about that. There is a QR code which you can scan, or just put that URL, the tinyurl.com ME detox beds into a Google search, and you'll bring this up. This will take you right there. Importantly, though, and Courtney asked me to make sure this point was made, you may see the number of beds listed, but it doesn't mean that that's instantly available to someone. So, for example, if you're operating Milestone, you have 10 open beds, you may only have enough staff that particular day to bring in 4 or 5 intakes. So, so that's the caveat that goes along with that. Next. What is a recovery residence? Interestingly, in Maine statute, the recovery residence term did not exist until 2019, when then Senator Shanna Bellows, now Maine's Secretary of State, promulgated a law, a rule, which is now a law, which defined recovery residences, established the standards for voluntary certification, and set up a pilot program operated at first by Maine Housing and now by us to offer stipends. We'll talk a little bit more about that later. But it's a broad term that they've been around for a long time. They've been called sober houses, halfway houses, three-quarter houses, that go by different names. But we simply define them broadly as describing a sober, safe, and healthy living environment promoting recovery. They mainly work on the social model of recovery. Most do, 90% work on that model. And what that means is that peers are both consumers and also providers, that they help each other. Peer-to-peer recovery support has been the success, the secret sauce, if you will, in recovery housing. There is a caveat, which is not highlighted, but I think is important. There's NAR, the national group, and I'll get to them in a second. They're aware that not every recovery house allows all mind-altering medicines, even though they may be approved by the FDA, Federal Food and Drug Administration. Some residents require abstinence from particular types of medicine, and that may be medicine for opioid use disorder, MOUD or MAT. I'm going to talk a little bit more about that later. Next. So we get to NAR, the National Alliance to Recovery Residences. They formed in 2011. A group of people around the country got together and they said, boy, you know, recovery housing is all over the place. Let's develop a set of national standards. And when they did that, when they tried to do it, they realized that one size did not fit all. They couldn't have a single standard. So they developed a system, a level system, and they numbered them level 1 through 4. And you can see on the screen what they are. I'm not going to read the slide, but essentially a level 1 we now call peer run. It's like an Oxford house where there's no paid staff. They operate under a charter from Oxford Inc. in Bethesda, Maryland. It's self-governing, democratically run. They vote on people coming in. They vote on people being asked to leave. And that's level 1. There is, again, no paid professional staff and not a lot of support for each other than each other being in that living environment. Level 2 or managed are what we have here. Mostly 80% of our houses in Maine are level 2 or managed. They almost always have a live-in house manager or someone nearby. The residents participate in their own governance with the staff and with owner and operator. There is some program structure. There's a house meeting, there's chores, there's group activities. There may be a requirement for so many 12-step meetings a week or other support meetings. There may be group activities they do together, such as community service. Level 3 does all that and more, usually though with some paid staff, greater structure, more supervision, and that's why that's called supervised. They're also more expensive, not really entry level as the level 2 houses are. And then level 4 or clinical actually has paid clinical staff. We have several of these, 3 or 4 around the state. Nicole actually is associated with Recovery Connections of Maine, which operates one of these in the Lewiston and Auburn area. And there's a few others around the state. These usually are they're expensive or they accept Maine Care or other insurances, and most accept Maine Care, so that the cost is covered by insurance. Next. It's hard to talk about where recovery residences fit into addiction treatment and recovery without looking at this slide, courtesy of the Recovery Research Institute. If you've not been on their website and want to know more about addiction, they're probably the best one in the country I can think of. It's operated by John Kelly, who's Director of Recovery Research at Harvard Mass General, one of the leaders in the world in addiction and recovery. And it's with his permission that we use these slides, which he created. But if we look at the timeline for addiction, the onset of addiction, which is not always easy to define, but in retrospect it is, it's often 4 to 5 years before someone actually realizes they have a problem and seeks help. And then it can be up to 8 years before they can actually attain a sustained remission, which we'll call for 1 year of continuous recovery. It often takes up to 4 to 5 efforts, 4 to 5 treatment episodes for an average person to achieve their first full year of sustained remission. We think about that for a minute. We wonder why, hey, if you go to the hospital for treatment for diabetes, you get treatment, they give you insulin, and you get better. You don't need 4 or 5 hospital admissions to get into remission from diabetes. You may, but cancer may be a better analogy. You often have to go back for multiple treatments and has periods of remission and active disease. The interesting thing is that after 5 years of full sustained remission, we call that stable remission, the risk of that person returning to use drops to about the same level as someone in the general population, about 15%. And interestingly, according to Dr. Kelly, 60 to 75% of individuals with substance use disorder will achieve full sustained remission. Not all through treatment, some do it spontaneously through religion or other means, but that's a pretty high number and one that gives me a lot of hope. Next. So if that's the timeline, we look at the pathways, and there are many pathways. Some people like to use the cannabis pathway. We don't particularly endorse that. We actually tried an experiment with that in our residences. 3 or 4 of our houses permitted it. It was a failed experiment. For 3 years, we reversed that policy. Just so you know, we gave that kind of a fair shake because there are people who advocate for that, but we don't do that any longer. We find that from the onset of addiction, it takes about 15 years for that person to recover, to reach the same quality of life that they had previously before they became a person with addiction. Interestingly, that timeline of 15 years to regain sort of your previous level of functioning, that can be shortened. And the studies that were done primarily involved recovery support services, RSS, and recovery community centers like the Barn or Portland Recovery Community Center or the 23 recovery community centers we have around the state. Why do you think the government, the Maine state government and Governor Mills invested so much money in recovery community centers? This is why, because it shortens that time for a person to get back to that same quality of life as the general population in two-thirds of the time, in 1/3 of the time, shortening that time by 2/3. That's meaningful acceleration. We see the same thing in recovery housing. We know the longer a person's in recovery housing, the greater their chances of remaining abstinent and other good things, which I'll talk about in a second. Next. If we look at the recovery curve, we see where recovery housing fits in, and not just recovery housing, but other recovery supports. On the left-hand side, like the x-axis, we look at functioning, quality of life, and well-being. When a person is through the medically managed withdrawal, aka detox, when their life is literally in shambles, things are a wreck, they're at their bottom, that's the house on fire. I mean, literally, their house is burning down. And some cases, it may actually be burning down. But once the fire is out, then we begin that initial 0 to 3 month phase of a person going, stabilizing in recovery. Early recovery, 4 to 12 months, the smoke's beginning to clear. And I like the analogy, with fire. And then sustained recovery, 1 to 5 years, that a person begins to reconstruct their lives and access the building materials to do that. We call this building materials recovery capital. And Peter's going to define that in one of his slides as we go further. But this is where recovery housing comes in these early stages, because even though you may be in a 28-day program or through a detox program, you're still terribly struggling, post-acute withdrawal, facing the wreckage of your active addiction, damaged relationships, in financial insecurity, legal problems, health issues. And that's why that curve takes it where that arrow is takes a downward spin. This is where recovery housing can help so much with support of each other and the programs that they offer. Next slide. So that brings us to MARR, and I don't want to talk too much about MARR. I'm happy to answer questions, but we were founded 5 years after the national group was founded in 2016. We are a nonprofit, a C3, a 501c3, although we started as a C6, a trade association, because it was started by 6 operators who got together. The 2 co-founders were Sarah Coop from Grace House and Dan Mahoney from Valdar. They still operate recovery houses, although they're no longer with the board, but they are members of MARR. They were concerned that there were houses in the state of Maine that were operating at less than ethical standard, and I think I'm being kind in describing it that way. So they heard about NAR. Massachusetts had a chapter a year or 2 ahead of us. They called them MASH down there, our counterparts, Maine Alliance of Recovery Housing in Massachusetts. So they formed a nonprofit. That's when I began to work with them. And at the time, all the board members were operators. And there's some criticism about, you mean you're inspecting and certifying, your own houses, and that might have been valid then, but of course it is no longer. The majority of the board members, by the way, are not operators now; they're members of the public. We have representatives from the legal community, from police, from the medical community, HR, insurance folks, lawyers. 2 lawyers, that's too many for a board, but we have 2 of them. So it's really become a board that people in recovery, people not in recovery, that really reflects much more of the recovery community. We are the only state affiliate of the National Alliance, therefore the only group authorized to inspect and certify residences in Maine at that NAR standard. Next. We do a lot, but I put it all in one slide. This puts it all in one place because I don't want to go on about it, but we provide information, technical assistance, especially to people that are interested in opening recovery houses. We started with 0, we now have 80 some. We handle complaints from residences via a grievance program, but also public complaints. Anyone can make a complaint from our website. But the grievance program separates us from the houses that are not certified because they have virtually no accountability. But we require that every certified house have the poster for the grievance program with the name and number of the grievance facilitator, who are trained volunteers, not MARR staff, not MARR board members, but members of the community in recovery themselves, who handle the initial grievances, and then they supply reports to us through our membership compliance committee. We do annual inspections, and we pay particular attention to fire safety and overdose prevention. If you look around the country and any deaths that have occurred in recovery houses, they occur in 2 ways: by overdose, which you would expect, and then by fire, which you wouldn't expect. Now, we've had 5 recovery house fires in Maine in 20 years. No injuries, no fatalities. Amazingly, no injuries, no fatalities, because people have paid attention to these things. They're not boarding houses, they're more like families. People look after each other. But we're very, very, very picky about working smoke alarms, fire extinguishers, egress windows, accumulations of combustible materials, and all that sort of thing. We don't have any ability to provide any oversight for non-members. Because of voluntary certification only, if you're not a member of our group voluntarily, then we don't have that ability. We can maybe call them, make a file, provide information for them, but quite frankly, most of the time they're not interested in hearing from us. We operate 2 housing support programs, and we're going to spend the rest of our time talking about these 2 and then Recovery Capital. One is the Housing Subsidy Services Program, HSSP. I know it's a mouthful, we just call it HSSP. This is the lion's share of the housing support that we operate. It's about a $1 million program annually. And we will provide for a new person coming into a house without the ability to pay up to 60 days of support, after which they will then go to another form of support, and Peter will talk about that. And then kind of my pet project, or ours really, at MARR, is the Bed Sponsorship Fund. Previously called the Bed Scholarship Fund, has been renamed. But that's money. We go out and raise this money ourselves. The staff, the board, we do the Real Recovery Film Festival. And we raise $30,000 to $40,000 a year, and we offer a $600 one month 30-day support. But we only can offer 4 or 5 of these a month, and they're gone quickly. Here's an example, because Monday was a holiday. The program opened midnight on Tuesday night at 12:01 a.m. By 9:15 a.m. that morning, all those spots were filled. Everyone had been filled. People had applied, they were interviewed and accepted in 9 hours. That gives you some idea of the need that still exists out there. Next. So, MARR by the numbers, 88 houses, over 1,000 beds. These are amazing numbers if you have followed us along from starting with 0. Our first house was inspected in January of 2017 with 36 different organizations operating in 12 counties. A lot of the other, let's go to the next slide, Peter, which has some of these as statistics. If we look at the split between men's and women's beds, it's about 1/3, 2/3. It's 1/3 being the women's beds. We do have some co-ed residents. Residents accepting MOUD, medication for opioid use disorder, it's about 80% that do. So we're talking about methadone, Suboxone, those sorts of medicines, Sublocade. That means there are still a number of houses that they are self-described as abstinence-based, believe very strongly in that. And we support the abstinence-based houses, but we don't support discrimination from under either the ADA or FHA, federal housing. And how do we approach that? We provide education so that these houses, if they would have a request for reasonable accommodation or reasonable modification, that they would know how to handle that properly under the ADA Fair Housing and not get into trouble with the Department of Justice. Next. The first program we're going to talk about is the Bed Sponsorship Fund, and I pretty much already gone over some of that. To date, we've awarded 60 sponsorships since we started about 2 years ago, with almost $40,000. We're down to our last $1,200, I'm afraid. So the program will end next month until we can raise more money. We currently have grants in process that Kate Reagan is working on for us, full-time staff person, partly devoted to doing that. But that program will have to close, I'm afraid, next month, and we're very. But if anybody wants to donate a pile of money, we'll keep it open. Next slide. And that brings me to my last slide before we go over to Peter. This housing subsidy program provides a bed night rate. So for every night that a person is in a certified house, in a state-funded bed, if you will, HSSP-funded bed, the operator will receive a set amount for that night. And if they're a level 3 house or in certain high-need rural areas, they may get a little bit more money. We require them to participate in data outcomes collection. That's called RECCAP, Recovery Capital Participation. Recovery capital is what Peter's going to talk about next, kind of a measure of the resources that a person has, both personal and community-wide, to get better. It's pretty simple. An applicant has to be accepted by the operator. Then they apply. Then if their bed is available, we don't become involved in making a decision. The operator makes their own decisions. And since the program started with us 14 months ago, we have funded 34,000 bed nights at 34,000 and change. And the total residents served have been over 1,000. If the Governor's Opioid Summit, we heard from Gordon Smith and others about how the overdose rate, the fatal overdose rate in Maine is dropping significantly. I'm happy to report it continues to drop, maybe another 20% this year so far, year to date. There's still lots of people dying, and one is too many. But how do we explain that we're only one of the 4 states in the country that had a significant decrease, 15% or more in 2023? This is one of the reasons, but only one. There are many of those reasons. The options program, the fact that we have flooded the streets with naloxone. Literally, there was ubiquitous now as paper clips and rubber bands in your drawers. They should be. And other programs, the availability of the medically announced withdrawal beds. You can't point to one thing, but you can point to many things, and we believe this is one of them. And I'm right on time. I can't believe that. That's like a miracle. Peter, take it away.
All righty. Thank you, Ron. So first, we're going to get into some high-level HSSP statistics. And as Ron said, in the beginning, this program is available to pay for someone's first 60 days of residency at one of our participating houses. And so one of the things I'd like to highlight first on this slide, and I'd like guys to keep it in mind as we progress through the other data slides, is the average length of stay is 34 days in the program. So even though people are able to stay for 60 days, and there are definitely some that do, the average stay is 34. So when we look at the data coming up, it's important to note that that is over an average stay of 34 days. We currently have 114 beds. We were thankfully just able to increase some allocations to people recently, and we have 64 participating houses. So this first chart here shows the reasons for discharge, and I'd like to also point out this is discharge from the HSSP program. That does not mean that the resident is actually being discharged from the house. It means they are no longer accepting this funding program, and that is when we capture this data. We're going to get into more outcomes when we go into recovery capital. But right off the bat here, we can see 40% of individuals switch to self-pay when they leave the HSSP program. An additional 20% are moving to another funding source. So just in those two categories alone, 60%, almost 60% of HSSP recipients are being discharged to a stable housing status. And if you add up the other categories that would indicate stable housing, you're looking at between 70 and 80% of HSSP recipients are being discharged to from the program to a stable housing situation. Our next chart here is our living situation prior to entering the program. And as most of us, I think, would expect, the three biggest being incarceration, residential treatment, and unhoused, and the next one after that being detox. I think that's pretty expected distribution there. And this is my favorite chart that we have here. So this is our employment status change. So this chart over here on the left is the number of residents employed 20+ hours on intake into the HSSP program, and that's at about 7.7%, so we're at about 8% on intake. And on discharge, that number jumps up to 32%. So a 4x increase. And as I noted a few slides ago, that's over the course of an average of 34 days. So that's a really good metric. A lot of those people are, as we just saw, continuing to stay in the house, whether that be switching to self-pay or another funding source. And that those employment numbers will continue to increase as they do. So next we're going to get into, what is recovery capital? Now, recovery capital takes into account every facet of an individual's life that can either support or obstruct their recovery. It is a systematized way to address the degree and quality of forces in one's life to help them enter and stay in recovery. So people are, when they enter a MARR certified house, about 85 or 87% of our houses are completing rec caps. They complete these evaluations at preset intervals. The first evaluation is completed on day 1 or within 72 hours of admission. The second evaluation is completed 45 days after the first. Third, another 45 days, and then that switches over to every 90 days. It's a preset, standardized data set that people or evaluation that people are taking. So when we are able to look at that data, we can really compare houses and see how the MARR network as a whole is doing. And another way to think about recovery capital is in economic terms. Someone's recovery capital is the sum of all the internal and external resources available to them to sustain recovery. For example, if someone has health insurance and access to transportation, those are two resources that can contribute to recovery and thus contribute to the individual's recovery capital. So since we started measuring recovery capital, September 1st of 2022, we've had almost 2,000 initial rec caps. So rec cap stands for recovery capital. That's what we call the evaluation. So that evaluation that happens within 72 hours, we've had almost 2,000. We've had almost 1,000 at the 45-day mark and almost 600 at the 90-day mark. So those numbers have continued to increase over time, and as we'll see in the next slide, they show very positive outcomes. So as I mentioned before, 77 of 80 of our 88 houses participate, so an 87.5 adoption rate. That's partially due to some cultural differences among houses and some lack of staffing and funding in some of the abstinent-based houses. All 64 of the houses in the HSSP program are performing rec caps, as it is one of the requirements of the program. So this first chart here, we call it the increase in or change in RCI chart. RCI stands for Recovery Capital Index. Another term, it's actually the new term for it, is called ORCS, Overall Recovery Capital Score. That's what the scientists who manage this are working on changing it to. So this is a high level summary score. When someone takes the rec cap, they're presented with a score screen. It goes through, their barriers, their unmet service needs, their strengths, and then it does at the top give them one score, which would be the RCI score, which is the compiled score of all the different aspects of the evaluation. And so we can see here, so this first bar is that evaluation that happens within 72 hours of being admitted to the house. And then if we look at the next ones in the column here, we have a 49% increase in RCI from day 1 to day 45, a 58% increase in RCI from day 1 to day 90, and continued increases as we go up, which visually you can see as the blue line coming up and just the bars continuing to increase in height over the course of the chart. So there's a lot more detailed data that comes out of this as well, but this being really the high level summary score, it really shows that people that stay in MARR certified residences increase their recovery capital over time, meaning that they are, furthering themselves down their recovery path and bettering their lives.
Hey, Peter, just to jump in for a second, there's a quick question in the chat about who collects the data for this, as it is sensitive.
Yep, absolutely. So I'll say, so this data here that MARR has access to is completely de-identified data. We have no personal identifying mark, no names, no email addresses, social security numbers, nothing that can identify an individual. The way the data is collected is by the operators of the house. So when someone enters a house for the first time, the operator's sitting down with them, getting them enrolled in the platform, and working with them to complete that first rec cap evaluation. And then past that, the client or the resident is actually able to complete them on their own, whether that be on a personal device or a house device. The operator, by nature of their role, is able to see the sensitive information, just like they are able to see all of their residents' sensitive information that they divulge to them. But MARR or any of the researchers that look at this data set that we're looking at right now, there is no sensitive information shared. So going into our next slide here, this is a little bit more of the detailed information. So this is reduction in service needs in MARR certified recovery residences. So our top 3 bars here, I realize it might be a little hard for some of you to read the side here. Our top 3 are going to be housing support, mental health care, and primary health care. So what that means is that as people have completed rec cap evaluations, during that first evaluation, these are the 3 areas that they have noted are their highest service need area, where they need help the most. And as we can see, as those rec caps are continuing to be completed, those service needs are dropping off. The top 3 that I mentioned, housing support, mental health care, and primary health care, do remain the top 3 as we continue to go down, but it's a drastic drop off in those various service needs. Similar slide here, but this is in barriers to recovery. So the top 3 we note here are work training and volunteering, accommodation, and substance use. And just like the previous slide, we do see a drastic drop off of those. Interestingly, on this one, though, they do not remain in the same order. Work training and volunteering actually drops into second behind accommodation as we continue as people continue to take those rec cap evaluations. So one thing we created, the team at MARR, somewhat recently, we're still distributing this to our operators. This is a guide for residents to understand their rec cap and make it useful. So I'll say I implemented the rec cap system with all of our operators, and in the beginning, the way I was trying to convey value was, this was the act of a 12 step for the resident. They were, or in another terms, they were willing to help and give their data to a de-identified data set that would be used to increase resources and support for those still in addiction, still suffering from addiction. And that was great, but it's kind of an abstract idea for someone that's especially really early in recovery. So this guide, which feel free to scan the QR code and read our digital version, tells a story of someone entering a recovery residence for the first time and how they, took a rec cap and how they used those results to influence their decision making and their actions, and how that in turn improved their recovery capital and improved their quality of life. So like I said, we are working on distributing these to all of our operators. Some of them have it. As I go see them, we're going to continue to give them to everybody. So thank you. I'm going to turn it over to Mr. Scott Party, founder and owner of Fresh Start Inc. and the president of our board. Take it away, Scott.
Thank you. Thank you, Peter. I'm grateful to be here, and I'm grateful to be sober today. And I do want to talk about, as the slide is showing, how have the funding programs impacted your business? I want to first tell basically what the population demographics is in Fresh Start. The two biggest ones is 35% came unhoused from the street, 28% from incarceration, and that's the rest from home or from rehab or by other means, a detox center perhaps, or a hospital. Those two being the largest, you can see how important it is for us to be able to take people in with no funds. And how important it is. We've always been that way, and it's been a struggle financially. So we have to look at funding. We are low barrier. I think Peter mentioned we're probably the lowest price in the state. He mentioned that to me last week. I'm not sure if there's anybody that charges less, but that's my understanding. And being really low barrier financially has its impacts. I will tell you that since 2000, and when we started in 2018 with one house, today we have 17 houses and 153 beds. And that also shows, the need, how huge the need is. And so funding is a huge barrier. We've only had to ask 3 people in that time to leave for funding reasons. We take it, I hate to use that term, but we take it on the chin for a fair amount of money. But fortunately, we have enough rooms to make that happen. So the funding aspect of it is a huge thing. The next question here, or the next talking point, is how has the outcome data impacted your business? We get a lot of repeat people from that leave Fresh Start for one reason or another and want to come back. This tells us how were they doing the first time? What was lacking the first time that perhaps put them back out? And by put them back out, I mean return to substance use disorder. And what can we do different? Are we doing what we're supposed to be doing? And the Recovery Capital Index, we look at this on a very regular basis. Because of our size, we have one person that's in charge of collecting this data. It's the only time staff isn't, let me modify that. The only time staff is involved is if somebody, when they first come in, or if they just don't really want to do it, and we kind of have to tickle them into doing it and go over with it them again. After the first time, they are able to get online and do it themselves, and that is definitely probably the better way, because I think if you're doing it yourself, you might be more apt to give an honest answer than if you're doing it with somebody else. We've also, because of our size, we have an office, and we try to have people do the initial one. We're experimenting with this, do it themselves on a terminal rather than us sit there and ask questions. And I think that's kind of changed ours a little bit to show that we're getting more honest answers when people come in. I know that because I've done a lot of those rec caps myself with people coming in. And have these programs helped? Has the HSSP program helped? Has the rec cap helped? Absolutely. We use it all the time. We're generally full. I believe we have a number of beds, and it's predicated by a number of factors, but we have a number of HSSP beds, and they're full. We definitely try to keep them full. Everybody deserves a chance, and with the population that we have, with 35% coming from the street, there's no funds. With 28% coming from incarceration, most have no funds, and this made a huge difference in a lot of people's lives. Ron had mentioned the reduction in deaths, and I firmly believe it's because of the size and the quantity of recovery beds that we have in the state, and the need is huge. We could add another, I don't know how many beds that we could add, and still only make a slight dent in the problem. The problem, as I see it today, is money. It's extremely expensive to live in this state. When you come from the street or you come from prison, it's a shock. It's a huge shock to see what it really costs to live in a place. And our mission is safe and affordable housing for people seeking recovery. And I hope I haven't overstayed my 5 minutes. Thank you.
Scott, that was great. Could you comment quickly on how outcomes data has helped you in applying for or receiving funding?
Yeah, sure. I know that as far as receiving funding goes, as far as we're pretty self-supporting. In other words, we require our members, we call them members, clients, housemates, to pay their way, and some can't. The city of Bangor has been works with Fresh Start very, very closely, and they like to see what we're doing, and we offer them this data. They're impressed. They tend to be of service to us, be of help. It's made a huge difference in money we're able. That's just from the rec cap. That's just from the rec cap. We have data to show them that this works, and it does work.
Thank you.
All right. Thank you, Scott. We'll pass it over to Nicole.
Hello, I'm Nicole. I'm the program manager for Recovery Housing of Maine. I wasn't planning on having a little one with me, but c'est la vie. So yeah, like I have lived experience. My substance use led me to incarceration. I did about 2 years in prison, and then I was released on the home confinement program. So when I was released, I looked at different options, and the easiest way to, for me, I didn't know anything about recovery housing, right? So for me, I started learning more about it, and it was easiest to be released on the home confinement program to go to recovery house, which was probably the best decision I had, ever made in my period of healing. So
Did we lose Nicole? Okay.
Hopefully we'll get her back. She was just getting started. There was a question in the chat from Edie Smith. Maybe I can address that while we're waiting for Nicole to come back. I guess I could read the question. That would be easiest. Do you know how many non-certified residences are in Maine, and are there efforts to try and get them under the MARR umbrella? So yes, we do try and get them under the MARR umbrella. Most rebuff our efforts. For whatever reason, they're not interested in oversight. And we think there's 20 to 25 of them, Edie. Because there's no accountability, no registration, there's no place we can go and look them up. We have to kind of find them one by one. And, here, we got Nicole back. Great.
I'm so sorry. My computer is just not running right. It just dies randomly. So I'm on my cell phone, so it's a little blurry. So yeah, when I was releasing, I was releasing to a recovery house, and I was very fortunate. I had funds saved up because I was working while I was incarcerated. I was at a reentry center, so I was working for Dunkin' Donuts, and I was able to have the funds to move in. But if I didn't have those funds, like a lot of places don't accept people without that, initial payment for rent. And then once I was released, I paid the first month, and I was taking time off of work because I was graduating college in a month. So I had to finish my classes and all of that. And I reached out to so many people to ask, like, what are the resources? Like, is there any programs that can help me pay my rent? And, this really wasn't available at that period of time, right? So thankfully I got a manager position, and that kind of changed the financial situation for me. But yeah, like working with folks now, not having to say no to treatment and recovery and safe housing because of financial barriers is probably like one of the most influential things in this person's like start to recovery. Like if people are worried about paying rent, I see it a lot of the times, they worry about rent or financial concerns, so they may slide into old patterns of behavior that aren't really safe, healthy, and aren't like pro recovery. So just having the HSSP program really helps folks out that way. And yeah, so we've helped a lot of people get, like, we don't really let financial reasons be a barrier for people to come to our houses, but it does, it does help. Like some people don't have an ID, so they can't get GA. Some people might have just ended a job and stopped working so they could get help. So whatever that looks like for them, like the HSSP program really helps them. And I actually can't see the slide on my phone, so if you want to remind me of the next, I feel all flustered now.
No worries. So the next one would be the outcomes data. How's outcomes data affected your day-to-day management of your residents?
Yeah, so it's really interesting to see. And because sometimes we forget, like if people are in the program for about 5 months, let's just say, for example, we forget, where they were at when they first came in, so to go back through and kind of compare them, it just really is able to show the growth that they've made. And it's really inspiring for them to be reminded of it. Like, look at this, like, you were here when you first moved in, and now look at you, right? Look at what you're doing. And it also helps with, for me to do my job, it helps me find what resources and support they might need more than others, right? So like if they're formerly incarcerated, they might need reentry support. They might need just different resources. So it does show the barriers to their recovery. And so I'm able to take that information and kind of create an individual plan for the person. But yeah,
those were great answers. Thank you.
Mm-hmm.
Yeah, sorry, I'm a little, yeah, I don't really think I have anything else.
we do have a few minutes for Q&A. Are there any in the chat or the Q&A, Richard, that we haven't gotten to?
No, it looks like we're caught up. Somebody did request the Q&R code that we saw in an earlier slide, if that could be put in the chat or even maybe bring it up again real quick. If that person is still on.
Yeah, that was Jessica. I'm happy to pull it up, Jessica. If you just, there was 2 QR codes. Which one were you looking for? The one for the guide or the one for the detox beds?
I think it was the guide.
Guide.
And then there's a question now, is there a listing of recovery houses in Maine?
Yeah, there is a listing of certified houses, and the last slide of the presentation that we'll get to in a moment will contain a QR code for our website. You can Google Maine Recovery Residences and get to it as well. On our website, there's a big blue Find a Residence button. That will take you to our directory where you can search by area and various other filters to find a house that would suit you. Back up the list.
There's another question for Scott. Does Maine Care pay for any services at Fresh Start? Also, what is the approximate cost of one person to enter recovery at Fresh Start? What are residents' expectations for payment? And if they can't make payment, are they referred elsewhere?
Okay, that's wonderful questions. Now, first of all, we don't offer any services, so we don't get Maine Care. We are fully self-supporting through what our members pay, clients, we call them members. The price is $165 a week, and that is works out to $710 a month. And that includes everything but food. And that's, I mean, everything, all the cleaning supplies, washer, dryer, internet, anything you can possibly think of except for food. And nobody goes hungry in Fresh Start. We have several local area churches that contribute boxes of goods. When somebody comes into Fresh Start, they get a box, and in the box, it's a nice sized box. There's some food, some snacks, hygiene items, and a prayer. And believe it or not, that those things, that box makes a huge difference to somebody coming in with nothing, or even if they come in with something. You know, it's definitely a wonderful thing. As far as referring people elsewhere, we have a really good relationship with the city of Bangor. Most of our houses are in the city of Bangor. All but 3 are in Bangor. Bangor is extremely supportive of Fresh Start. Their general assistance, when say HSSP runs out, their general assistance will pick it up. We've, like I hope I mentioned earlier, we've only had to remove in the last, since we started, which was almost 6 years ago, we've only had to remove or asked to leave 3 people for non-payment. And it was blatant. You know, it wasn't like they were struggling. We typically 10%, if you're in the rental business, and I don't like to say that, but if you are in the rental business, you're the norm is 10% vacancy rate. We don't have any vacancy rate, but we do have a non-payment rate which equals about 10%. So it's figured in. You know, last year, for instance, you know, it was tens of thousands of dollars that Fresh Start ate. But because of our size, it's kind of a numbers game. You know, one house is down, the other house is up. We have 17 houses, so for somehow it works financially. You know, we are a nonprofit. We do have people that occasionally donate money. Anybody that donates money to Fresh Start, that money doesn't just go into a hole. It is donated to somebody's rent. We do not have any other placement of funds if somebody donates funds. So somebody gets a gift of rent when anybody contributes to Fresh Start. I hope that answers your question.
Thank you. We are running down to the last couple of minutes. There was a question in the chat what is the best or fastest way for an individual with Medicare, Medicaid to get into detox? They've actually experienced difficulty trying to assist neighbors in my building when they wanted to go to detox, ended up waiting at the ER. Anybody have a good answer in 1 minute?
Richard, I'll take that. The reason why we started our slide presentation with that information on the beds in the 6 facilities that offer them, as well as the link to, that's the one, as well as the link to the bed availability. So you've got everything you need there. You've got places with available beds. You have phone numbers for each of those places on the chart. But you've got to get on the phone and start making arrangements. So it's not self-service, and it's not something you can apply for over the web. If we don't use those beds, we're going to lose them. So my experience and frustration over the years in trying to get people in and failing time after time and seeing people die as a result, actually, sadly, in some cases, hopefully those days are over.
Well, I think we've just about 1 minute left. If you'd like any closing remarks, Ron, got 1 minute.
Well, extremely grateful for the participation. Also, I want to thank Amanda Rickey for putting in the chat the Recovery Direct, the free service that helps people find treatment beds, recovery house beds, and also helps to provide for transportation when possible. Our organization does not do assessment, referral, and placement. We have no resources or staff for that, but we end up doing a lot of it anyway. People call us and say, hey, I got, my mom or my son's getting out of treatment here next week. We live in this area. Can you point us in the right direction? And yes, we'll be happy to do that. But then they have to call the operator and make the arrangements themselves.
Well, I want to again thank the panel today, Ron, especially for a wonderful presentation, very informative. And it's just it's great work for the community, and I really appreciate it. The state appreciates it, and stay tuned for the first week in October for the next webinar. And long range, we're all looking forward to the 7th Annual Summit next July. So thank you everybody for joining us today, and if you're planning to listen to the recording, I hope you get a lot of information out of it. Thanks again, panel. Thanks, Ron.
I want to thank
Thank you, everybody.
And also Lorena from AdCare for doing all this work behind the scenes. She's amazing.
That's it, Lorena. Thank you.
Thanks everybody.
everybody.
Thank you again, everybody.
Thank you.
Thank you.
Great work. Great work.